Welcome, everyone.
Okay, well, as we get going, we just want to give you a little bit of context for this virus. And I know many of you are reading the news, but as of a half hour ago, the Johns Hopkins dashboard shows about 1.4 million people worldwide have been confirmed with documented infections. In the United States, that's just over a third of a million people now, with 15,700 deaths now reported. And in the state of California, that's almost 20,000 cases with about 500 deaths reported. So moving now from the national, state, and global context to our more local context, one of the really neat things that we've been working on is a combined dashboard across the 5 UC medical centers. So that's what's pictured here. This goes out every morning to about 300 people. It's actually technically hosted through UCLA. And you see the combination here with yellow representing UCLA and orange representing UC San Diego for our daily tests. On the right-hand side are all the different ways that we order those tests across our 5 medical centers and 4 instances of Epic. And so that represents an important concept, which is a lot of data normalization occurring. We can also see on that dashboard the rate of rise of infections. And so again, that yellow line represents that Dr. Pfeffer in Los Angeles is bearing the brunt of some of this infection. And on the most recent dashboard just added today, we're also looking at our ICU and inpatient capacity, which is represented in the lower left. I do want to point out that Dr. Carrie Byington, the Executive Vice President of Health, has committed to transparently sharing these metrics. And so that University of California Health Twitter handle actually shares this data on a daily basis, and would encourage you to follow that if you're interested. Locally, we have a dashboard here in UC San Diego, and of course all 5 medical centers have something similar. This is our dashboard from this morning, Wednesday, April 8th. I want to give a shout out to our analytics team led by Josh Glandorf, Jennifer Holland, Eugene Lee, and all of the team members there. We distribute this dashboard now to every single member at Health Sciences at UC San Diego. So over 14,000 employees receive this. And it shows, without divulging any protected health information, that as of this morning, we had 19 COVID patients in-house. And of our 35 patients on mechanical ventilators, 8 of those are actually COVID positive patients. We can also see over here on the left that 50% of our outpatient visits yesterday were video visits, and Mike's going to be talking in a minute about telehealth efforts. And then we've got a breakdown of our beds and where our patients and tests are as well. So I'd say if there's one silver lining to the COVID crisis, it's really enabled our organization to focus on being data-driven and analytics-enabled. In fact, our electronic health records are sort of an infrastructure for a lot of the work that we do. And the team at UC San Diego got a quick paper out on that in this journal, American Medical Informatics Association. You can Google the paper, but here's the key table that talks about all the different ways that we are leveraging our electronic health record to help. And so that's a good segue to the patient-facing technology. And I'm going to hand this to Mike to talk about their telehealth efforts.
Yeah, so this is an example of the way we're tracking telemedicine at UCLA Health. And I think what's really been spectacular across the 5 UC Health organizations due to the ability of the IT organizations to scale is the rapid uptake and implementation of telemedicine across the environment. With the stay-at-home orders or shelter-at-home orders in the state of California, it's incredibly important that we offer our patients ways to connect with physicians in a safe way. Now, not all visits can be done through telemedicine. That's why we still have clinics open. So patients that do need to come in for in-person visits can. But you can see on the right side here, prior to when we started testing for COVID-19, we did very little video visits at UCLA Health in the order of, a few hundred a week. Now we're doing over 2,500 a day. And that ramp up, you can see as the graphs went up there. So really, really incredible growth in this sector. I don't see it going backwards. I think telemedicine is here to stay. And I also do want to give a shout out to the telemedicine team and the analytics team at UCLA Health for putting this together.
Another one of the ways that we're trying to help is by deploying new technologies to help with diagnosis. And so really exciting, our clinical research IT teams led by Dr. Mike Hogarth in collaboration with a number of our health information services teams, including Andrew Greaves and his colleagues, moved an IRB approved clinical trial into production. So in our radiology storage system, which is called a PACS, every chest x-ray and chest CT scan is now automatically processed by an algorithm from Dr. Albert Schau's lab, and areas of likely pneumonia are highlighted. And this is important because radiologists spend a number of years studying how to best read these films. And physicians like Dr. Pfeffer and I do an okay job, but less than a radiologist. And so this helps us sort of have a radiologist at our fingertips 24 hours a day, 7 days a week. Just last week in our emergency department, I was rounding and talked to an ED attending who had an 82-year-old patient who received a chest x-ray, not because of respiratory symptoms, but for other reasons. And the chest x-ray came back with a mild AI finding. Based on that, the ED attending actually ordered the COVID test, which interestingly returned positive. So we're studying this very closely, like we do any clinical research effort, but it seems like a promising new tool, and it's exciting. It's also neat that we were able to move this algorithm out of a server in somebody's research lab into Amazon Web Services, and that algorithm now running in AWS has processed over 2,000 images locally at UCSD, and we're sharing that with other health sites as well. So that's kind of a quick overview of some of the ways in which our teams are helping. And Mike and I both want to thank all of you for helping to save lives. We know that just like our health departments, the campus departments have been rapidly deploying technology and hardware to support remote work and remote learning. And all of that is supporting the social distancing that we know is decreasing the spread of this virus. And so all of you are helping us to save lives, and Mike and I both want to thank you. So we'll turn this over to some Q&A now, and we'd ask you to use the Q&A button to go ahead and share any questions that you might have, and we'll do our best. Mike, they might be a shy bunch. Do you have any comments?
Well, we did get one question, which was, where can we get this dashboard? And I'm not sure which dashboard is being referred to, but the UC Health dashboards that we showed on the slides, which combined all of the testing data from all 5 of the sites, can be found on the UC Health Twitter feed. So that's where you can get those delivered. I think they're posting them daily now. They're tweeting them daily.
Yeah, it's about 4 o'clock every day.
Yeah, so that's where you should go get those dashboards.
The next question is, are you having any challenges with the technology for conducting video visits? And I can't speak for Mike. I would say that San Diego, that we've had very high success rates overall. And we credit that to the fact that we did have a telemedicine program before the pandemic hit. And so we put in place a lot of infrastructure and processes to do this. But of course, we had to scale it rapidly. Our vendor partner, Epic, actually doubled our server capacity to ensure that we could accommodate it. And our video license partner increased our video licenses so we could hold more concurrent video visits. We have had a few failures, though, for one reason or another. And when that happens, we have a process for flipping over to a telephone call or a backup option.
Yeah, I would agree. I think the technology has been pretty rock solid. I mean, there have been some glitches with the cloud providers, but for the most part, when ramping up this quickly, you need to get patients on the MyChart application. And sometimes, you know, they forget their password, or there can be some confusion in downloading the app. So really making sure patients are set up and ready for a video visit makes it much, much more successful. they're not, and the physician has to convert over to a telephone call and try to walk them through the process, it doesn't work. So that's kind of where we're seeing some operational issues, but that's to be expected when you go from, 100 of these a week to 2,500 a day.
So the next question, Mike, is the curve flattening? And I would say that there are some hopeful signs that the curve is flattening in California. Some of the models used nationally and mentioned in White House briefings show a expected peak in mid-April. That being said, we also know that same model has underestimated our amount of ICU bed utilization currently. So the models are only as good as the assumptions that you put into it. We do know that doubling rate in San Diego County has gone from 6 days to now 8 days. I think in Los Angeles, Mike, that you guys are up to 6 days now.
Yeah, it's really hard to predict what's going to happen. I think what we have seen, though, overall is that social distancing has been quite successful. We also, our geography, I think, if you compare us to New York City, for example, we're much more spread out. We lack significant mass transit, at least in Los Angeles. And so for once, that's actually in our favor, and probably explains a lot why we're seeing different results than New York City.
Yeah, interestingly, both California and New York City had the same number of cases 2 or 3 weeks ago, but obviously they're 10x ours now. And there's a bunch of hypotheses around why that might be. One of them is the urban density that Mike mentioned. Another is that our social distancing policies were instituted earlier in California. And there's an interesting third, which is that recent data shows that pediatric patients, children, are much more likely to be asymptomatic carriers of the virus. And so there's some thought that the school closures are one of the most effective ways to prevent spread. And we'll see how that plays out.
Yeah, that's a really good point, Chris. And I think California did a really good job closing down schools earlier than New York.
So that goes to a next question here. Somebody asked, what type of COVID-19 testing is UC using? Do we have the antibody testing? I can say across all 5 sites, the medical centers have developed in-house tests. And that's those are viral load tests based on the RNA and the virus. And so we're all performing those tests, as you saw on the dashboard. In addition, we are working on the antibody tests. Mike, I don't know if you have that live yet at LA yet.
No, I think we're partnering with a third party to do that. So it'll be a send-out lab, as far as I understand. The in-house test is a reverse transcriptase PCR test to identify the virus itself.
Yeah. I do know that there's a study out of Stanford to do antibody testing on a population, because another hypothesis around our flattened curve in California has to do with the possibility of earlier exposure to travelers from China. So we just don't have the science and the answers on that yet. I think that question does relate, though, to the next question, which is you displayed a Twitter handle and suggested following it. Both Mike and I have our Twitter handles listed there. And the other one that we had mentioned right here is the University of California Health, or U of CA Health, which is where these dashboards are getting posted on a daily basis. And credit to Dr. Atul Butte out of UC San Francisco, who also serves as the Chief Data Science Officer for the University of California Health. He and his team have been doing the data aggregation to make this possible.
Okay, so there's a lot of really great questions here. So we may skip some, and I apologize for that. One of the questions is, are you moving to inpatient telehealth visits? That's a really, really great question. And I think there's a lot of benefits to inpatient telehealth visits if done appropriately. And I think each of the 5 sites are in different kind of maturity levels around this. At UCLA, we're actually piloting now what we're calling a no-touch Zoom technology that basically is discrete for each patient room. And a physician could start a Zoom meeting with a patient without anybody having to go into the room to set it up. So we're very interested in how that pilot's going to go. But I do think there's a huge opportunity around this, especially in terms of reducing the PPE needs for many, many people going in the room. And there's lots of different examples about that. And the other thing is it's not just physician specific. So many different ancillary services in the hospital could take advantage of something like that.
Yeah, at UC San Diego, we've also deployed inpatient video visits with Zoom technology, and similar to Mike, we've custom written a dashboard that allows our clinicians to sort of click on a patient room and call them. And I would credit the collaboration across the University of California health sites for helping with that, because they've got a call every Friday that they trade best practices and lessons learned. And I think that's helping all of us kind of raise the bar. A couple more questions there about predictive tools and is the AI diagnosis tech being shared outside of UC. Again, there's a press release on this from UC San Diego. We have offered this across the 5 UC medical centers. Right now, that's being deployed under an IRB, and so the IRB reliance across the sites helps us to do that. Until the research study is done, we would not offer that outside to other health systems, since it's still a clinical research trial. And then a related question, is there a pathway for integrating more predictive tools for COVID-19 into clinical workflow? And I think that relates to how these AI tools are developed. There was a third question I saw about, was the imaging data set just University of California? The answer was no. There was actually a public data set out of China for COVID x-rays that is how that algorithm was trained. But obviously, we're hoping to improve the algorithm as we feed more data to it. And we just have to be very careful with AI tools that we're not introducing inequities and disparities unintentionally. And so it's really important, we think, that we study these tools carefully to make sure that we're not introducing unintended consequences before we release them too broadly.
Yeah, one of the things I'll also say about AI is there's actually a lot of artificial intelligence in the electronic health record in terms of decision support that all of us have built in to help guide providers when to order the right tests, not to replicate the testing too early, how to make sure we properly isolate people. So not all AI is machine learning and predictive. A lot of AI is really guiding clinicians based on evidence to do the right thing. So a lot of work by all of the Epic teams at all the sites have gone into really thinking through that level of decision support. And you'll often find that in situations like this, predictive analytics are not really where we're going to turn to, because they're not well proven. They need to be studied, and there's too many unknowns right now. So what we do is we have kind of more real-time decision support that we can change based on what we're seeing in terms of our data and analytics, and build that into our electronic health records. There's a question here. There's so many great questions here. One of them I think is worth talking about. Are you doing anything to help improve the security of end users at home? And one of the things that I think is unfortunate about the pandemic that we're seeing is that hackers are really turning this into a field day for them. And I'm not surprised, but you know, this is, so on top of everything that we're doing, we have to be even more concerned about our security posture. So there's very little we can do about, you know, home Wi-Fi setups. That's really, really tricky. But we can do our best to make sure that our home users follow good computer hygiene, as I call it, provide them with secure VPN connections, as well as two-factor authentication. At UCLA Health, we have a Citrix-enabled remote desktop client. So people can use their home computers and remote in to their desktop computer through Citrix, which gives us a significant level of protection, as opposed to just the remote desktop client directly on the home device. And we're looking into many other things that we could deploy for our home users, such as advanced malware protection. So that's a really great question. And it's a combination of working very closely with IT departments, but also a partnership between all of our customers to really pay attention to what's going on in the security space.
So another good question, do you see any permanent advantages to televisits that would entice you to retain them over the long term after return to normalcy? And the answer to that is undoubtedly yes. I think that the world has changed very rapidly. And with most of the medical centers now at 50% more televisits, all of our physicians are getting experience that most of them have not had before, as well as our patients. Part of what's driven that is both federal and state relaxation of telemedicine rules. And there's already been a lot of discussion at both the federal and state level about more permanently relaxing those rules rather than returning to the previous state. Because it's clear that telemedicine can deliver a better patient experience and more convenience. That being said, we also have to be cautious that we don't deliver too much telemedicine. As Mike said, we still have our clinics open for in-person visits, and it's important that some conditions are seen in person for physical exams and procedures and other things. And so there's a new balance or new equilibrium that we expect to achieve.
Let's see. Great questions. A lot of questions around why are we seeing low COVID-19 numbers relative to the total population? Is social distancing working? Those are all really good questions. I mean, I would say social distancing is working. And, there was an interesting study recently out of Iceland with, I think Decode was one of the companies that basically found that 25 to 50% of the population was asymptomatic. So, this really boils down to patients who require hospitalization versus those that don't, and the ability to test. So we don't really know what the denominator is because we're not testing everybody in the population. We're only testing those that are symptomatic. And even if they're symptomatic, we may not be testing them. So we don't really know what the true number of COVID positive people are in the environment. But the fact that we are not seeing significant spikes at this time in our hospitals is a really good sign that social distancing is working. There's probably people that would say that social distancing is not needed because the numbers are so low. And I would argue that that's the opposite, that it is why we're seeing low numbers, but we are still expected to see a spike in the next 1 to 2 weeks.
Another question here is, are you releasing both negative and positive results of COVID testing to MyChart immediately? That's a great question. We've all deployed MyChart a little bit differently across the 5 systems. When this started, because of the burden of calling all our patients, UC San Diego did release all negative results immediately. We recently added in positive results for immediate release as well. And shout out to Dr. Russ Kachina and the team at UC San Francisco. I know that they release all lab results immediately. And so a little bit of variability. We've got a great group working on standardizing MyChart across the University of California.
Yeah, one of the things we did early on at UCLA Health, and again, a shout out to analytics team, Joycey and Vu, we published our testing results to everybody at UCLA Health. So anybody who worked all our, almost 30,000 employees could see on a daily basis how many people we were testing, were they positive, negative, and how many people were hospitalized in real time, not in real time, but the day before, for a COVID-related infection. So I think the power of analytics is transparency and allowing people to feel comfortable with knowing what's going on. And I think that's really, really important. We have such incredible physicians, nurses, all of our frontline staff that are caring for these patients and giving them the ability to see at a larger scale what's going on at our health system, I think is really, really important. So, it's just amazing what we can do now with analytics across the 5 UCs and bring all that together, especially around potential research opportunities to see what we can do to improve the outcomes of patients with COVID-19.
Yeah, and speaking of analytics, another question here from Linda. Are UC hospitals experiencing any shortage of PPE and ventilators? Certainly a concern across the state. And another great example of analytics, we didn't have a terrific handle on our PPE supplies previously. And as a result of this effort, we've tied our Tableau and data warehouse directly into our supply chain system, validated, and we now have a much better daily handle on PPE. The short answer is no. We're tracking our burn rate closely, and given all the supply chain increases, donations from Tesla, Benioff, and others across the state, we're not projecting shortages of PPE, ventilators, or ICU beds at this time.
Yeah, lots of really good questions here. I know we're nearing the end of the session, so maybe we'll take one more question, but I do want to say thank you for all the questions and for attending. And if we didn't get to your question, I apologize. But these are all really, really good questions. Let's see.
Yeah, I think we can work with Yvonne to get something out on the UCIT blog.
So we can end with this one here. Any suggestions on how we can remotely help our elderly patients sign into televisits? So this is a really, really important question. And I think one of the consequences of ramping up so quickly was this issue. And, you know, ideally, patients would come into the clinic, they would be set up with their MyChart accounts, someone would show them, you know, in this particular case, so that the next time they do a video visit, it's all set up. We don't have that luxury now. We've been moving very, very quickly. So basically what we've been trying to do in this area is create a lot of instruction, have an 800 number that people can call and walk them through the setup, as well as we're going to be creating a video to kind of help people do this as well. I'm sure all the 5 sites are looking at how to do this, but this is an issue. There's certainly inequity with video visits, right? You need to have a phone, you need to have cellular service or Wi-Fi service. So it's not a perfect solution for where we are today. But at the same time, if we didn't have televisits, thousands and thousands of patients would not be able to get the care they need in this pandemic. So definitely things we need to think about. And I welcome actually all of your suggestions on how we can do better in terms of delivering telemedicine to all our populations in California.
Yeah, one of our primary care providers at UC San Diego had a televisit yesterday with a 98-year-old woman who set it up on her own, and she was very proud of herself. So I think on that note, we'll wrap up. Again, want to say thank you to Mark Cianca, Yvonne Trevis for setting this up. Thank you to my colleague, Dr. Pfeffer, for joining. And thank you to all of our health IT teams for their response, as well as all the campus IT teams for supporting social distancing and remote work and remote learning. So thank you, guys.
Thank you all.